Good morning, and thanks for the opportunity to come and speak to you today about some of the things that are really core to the business of my team at Safer Care Victoria. I manage the incident response team. We sit within the Consumers as Partners branch within Safer Care. That's quite a deliberate decision made by Safer Care, and it's to align the fact that when we look at when things go wrong in our systems of care in health, we've got to remember that the person who's ultimately affected at the end is our consumer, our patients and their families. So that's a very deliberate decision. But what I wanted to talk to you about today is for probably three main things. I could talk about incident review and learning from incident reviews, ad infinitum and for days on end. But what I wanted to focus on today is challenging the way we think about and the way we look at when things go wrong in health. Because the lens of a clinician, although it's very important, isn't necessarily the best lens for improving system safety. Okay, and I think we've proven that for quite a number of years now. That slide that was shown earlier by Stephen that showed that medical error, and I challenge that term error, but that medical error is the third leading cause of death in the US. That hasn't changed in like 20 or 30 years. We've known that, and it hasn't changed. Okay, and there needs to be some fundamental changes in the way we look at what we do, and the way we learn from when things go wrong, in order to change that figure. The other thing I want to do today is just look at some guiding principles. Again, they're very high level, so that when we do look at when things go wrong, we're applying a more fruitful lens, if you like, to learn from that event. And I also want to share with you some of the things we're doing at Safer Care to try and help health services learn and improve when things go wrong to make our systems of care safer. First thing I want to talk about is the way we think about things. I'm actually a clinician. I'm still a practicing clinician. I'm a critical care nurse by background. And I've been a clinician for about just over 30 years now. But 15 of those years I've also been working in and around something called human factors, which some of you may or may not know is an applied science that draws on lots of elements of scientific knowledge. Okay, so it's everything from physiology to anthropometry to ergonomics to all sorts of disciplines, cognitive psychology. Okay, and it applies the knowledge and methods in those scientific disciplines to actually look at how we can optimise human performance, make that performance safer, and make sure that there's good well-being for our individuals, our individual workers. And one of the things I've learned about human factors is the way we look at the world as a clinician and the way we look at the world from a system sense is not the same. It's really quite different. Clinicians, and these are some of often when clinicians are in root cause analysis teams looking at when things go wrong, often what I read in the reports which come to Safer Care Victoria is that human error was the problem, and that's the finding. Okay, from a systems perspective though, human error is just a symptom of a broader problem. Okay, if you think that anybody has come to work with the intention of making a mistake or hurting anyone, I think that's a really dangerous assumption. Okay, and we need to start challenging that assumption. Nobody comes to work with the idea they're going to hurt anyone or make a mistake. Okay, so it's just a symptom of a bigger problem in a broader system. Healthcare professionals are socialised to strive for error-free practice. There's been quite a few papers that have looked at the similarities between surgeons, for example, and pilots. And the different cultural views and the self-expectations they put on themselves for perfection. Okay, and I'm not saying that that's to strive for high performance is not a bad thing, but to frame it that we shouldn't make mistakes is just completely and utterly unrealistic. We're human. Humans make mistakes. That's part of our nature, and that's part of the way we need to look at when things do go wrong. Okay, we need to understand that human error is inevitable. Okay, and the systems that are designed by humans, they're going to fail. Okay, but the whole point of it, okay, is not to become perfect, because that's just unrealistic. Okay, it's actually to make a stronger system so that will capture when things go wrong and stop it from harming a patient. Okay, capture those human errors and stop it from harming a patient. Or if it does hit the patient, so to speak, then we can actually make sure that it doesn't harm the patient too much. Okay, we can retrieve the problem. Error is often seen as a failure of character. Okay, we have a terrible culture in health of name, shame, blame, retrain. Okay, and that's really got to stop. There is no point saying it was that junior doctor's fault because of the decision they made, or because they wrote the prescription down wrong, or because of whatever the reason may be. Okay, and again, they didn't come to work with the intention to do that, so it's really unhelpful to blame individuals. Okay. Medico-legal landscape and the focus on individual accountability does result in a culture of blame. Okay, and this is with due respect to my colleagues in the audience who are from a legal background. Law by its nature is adversarial. Okay, and it has its place. Okay, in defining what we do, in regulating what we do. It has a role in defending medical practitioners and health practitioners generally. It has a role in standing up for the rights of consumers who are harmed as a result of their healthcare. Okay, but from an improvement perspective, okay, the absolute medico-legal lens is not necessarily helpful. All right. Really, we need to be looking at things from more a just culture perspective. Okay, we need to look at balancing better the idea of systems versus individual accountability, which is essentially what just culture in part does. All right. Health professional training tends to encourage prompt recognitions and symptoms and rapid diagnosis. Yep, it does. Okay, but when we apply that to an investigation context or to a review context, we can't often get those rapid results. We can, but we'll often not be looking in depth enough at the problem or at what happened. All right, that takes a bit of time. So rapid diagnosis, okay, or that as a skill is not something that's helpful in a review context. All right, we need to take the time to really look at what happened and really consider what happened and really consider the multiple things that impact on human performance. After an accident, safety is primarily improved by retraining the individuals involved. That's part of that name, shame, blame, retrain culture. Let's just put them through this education program. Let's just fix them that way. Okay. If we look at where training sits on a hierarchy of controls from an engineering perspective, it's the second least effective thing we can do to actually improve the system safety of what we do. Okay. It doesn't mean it's not important. Training's critical. It's a really, really important element. But unfortunately, it's often offered as the only solution to actually fixing a problem. Okay, and as we know from most educational research, most of what we learn degrades over generally a 6-month period. And so by the time we've learnt something after about 6 months, unless we've actually revisited on a regular basis, we actually don't really remember how to apply the knowledge or how to do the skill effectively. From a systems perspective though, we can't necessarily change humans or the human nature through training, okay? But we can change the context or the systems in which people work. And that really needs to be much more of our focus, okay? So the way we think of as a clinician is really important in many ways when we look at when things go wrong, but we need to be careful about the lens that we apply when we're reviewing and learning from adverse events. Some of the principles that, again, I can't go into this in great depth, but some of the things that we need to think about, I think, leading from that, some principles to improve the way we learn from surgical and other adverse events is to keep that focus on learning. Okay, and one of the great, I think, quotes from Sir Liam Donaldson, to err is human, that happens. To cover up, it's completely unforgivable. Okay, And to fail to learn is utterly inexcusable. Alrighty, so focusing on learning is really what we need to do. We need to get rid of the blame language. This notion, in that BMJ article from 2016 that Stephen had on his slide, it uses the term that medical error is what's to blame for, is the third leading cause of death. And that's actually just not true. That's blaming healthcare professionals, it's blaming doctors, it's blaming surgeons for those deaths. Not one of those surgeons, I would argue, or doctors or nurses or whomever, came to work with that intention. So it's the wrong language to be using, and it's not helpful. Okay, I'd call them systems failures in health, is the way I'd frame it. Another principle to think about when you're reviewing when things go wrong is your own bias. Up there is a codex of all of the biases that impact on the human brain that have been identified by psychological science. Okay, there is, I think, over 350 odd of them in total. Some of the main ones that impact us tend to be, when we're looking at when things go wrong, is hindsight bias. You know, that fabulous retrospectoscope can really influence the way that we look at a thing, we look at an event. It's very easy to say, oh God, there's no way I would have done that. Well, of course you wouldn't have done that. You weren't in there operating on that person at that time under those conditions. You know, so hindsight bias is very, very problematic when it comes to the way we learn from adverse events. We also need to understand the biases, though, that impact the clinicians that were involved in the event that we're looking at. Okay, how many of them had a fixation error? Okay, that's one type of cognitive bias or one type of cognitive problem. All right. Other ways we can actually improve the way we look at when things go wrong, keeping a focus on systems improvement. Okay, again, that focus on individuals. Whilst individuals might need more support on a case-by-case basis, if that's the only thing you find in your review, you've not found enough. Okay, and I'm talking more about reviews like root cause analyses and those sorts of team-based investigations. Okay, so there needs to be a focus not just on individual staff factors. Okay, we need to consider patient factors in part. We need to consider how staff work together in teams. We need to consider the environments in which they work. We need to consider the organisational and management context, the policies, the procedures, all those sorts of things, the leadership abilities. We also need to consider the institutional and context factors, the regulatory environment, the laws that affect what we do. And we also need to think about the task and technology factors that impact across all of those as well. And we talked a little bit before about just culture and a just culture lens. What a just culture lens really tries to do and really tries to understand is an error, why did it make sense to them at the time? Because there must have been a reason, there must have been multiple reasons. Okay? And is it possible that a similar person with similar experience and training in a similar situation under similar circumstances and conditions would do the same thing? Okay? That helps us really balance that view of, do you know what, it's not just about what one person does, it's about all the things that influence what they do. Okay, and that's what the just culture lens tries to balance. One of the other principles that I think we need to try and do more and more of, both within health services and across health services, is learn to collaborate and engage better to improve safety. We need to make sure that when we review when things go wrong, that there is multidisciplinary input. There's different ways of looking at things. Where possible, if you're undertaking a serious adverse event investigation, you're doing an RCA, okay, you really need to have, or Safer Care Victoria now requires you to have an independent expert on your panel. Okay, somebody who's not biased by your organisation, who's not subject to any influences, any way, shape or form, and can offer maybe a very different perspective. Okay, and similarly, more and more, we're going to actually be requiring health services to actually have a consumer representative. on those root cause analysis panels. Okay, because the consumer lens is completely different again. As clinicians, we can get very, very focused on, the technical aspects of what went wrong, the operational impact, all those sorts of things, and we kind of forget that whole overlay of human experience. How has it really affected people, and how can what we do as clinicians, and how can we design our systems to actually make the patient experience a whole lot better, even though things go wrong from time to time. And healthcare is a risky business. It will go wrong from time to time. Okay. The other thing I think we need to make sure we have on all RCA review teams is people who are actually qualified in incident analysis and people who have an understanding, at least, of human factors and systems thinking. Okay. Not every clinician can come with that skill set, but somebody on that review panel needs to have it. Okay. There's lots of RCA review panels that don't have anybody who's RCA qualified on them. Okay, and you can see that in the report, and you can see that in the value of what is learned. Okay, in the report. Engagement with other stakeholders in staff. Helping them to feel heard, included, and informing them of the outcome. How many of you as clinicians have been involved when something goes wrong, an incident report is put in, and that's all you hear about it? You know that a review has gone on, but you never hear the outcome. How disenfranchising is that as a clinician? How can you help improve and prevent that from happening again if you don't know what the outcome of the review was? Okay, that needs to be core and routine to what we do. We need to more and more understand what work is as is done as opposed to work as is imagined. Okay, so to say that, okay, the clinician didn't stick with the policy or didn't stick with the guideline, okay, that's saying, well, have we really considered work as is done versus work as is imagined, the policy? Is the policy actually fit for purpose? Does it actually reflect the constraints and the issues that clinicians have to deal with every day in delivering good care? Does it set them up for success, or does it set them up for failure? Okay, and it's very easy, again, as a review team, to knowing the outcome, that's an outcome bias, with hindsight, making a judgment on the performance of a clinician. Okay, but we really need to often understand what are the constraints on their work as is done, not just what the hospital policy says or what we expect them to do or what we think they should do. And part of that is understanding how and when people make trade-offs to balance and achieve system goals. It's very common for clinicians to take shortcuts and those sorts of things in order to meet neat targets, in order to meet, whatever, surgical timetables you might have, the operating theatre timetables you might have. Okay. Sometimes they're okay, and sometimes we can actually learn from those and we can actually become more efficient from them. Okay, but sometimes they actually bypass fundamental safety elements, and we've got to really think about, are we setting our clinicians up for success by forcing them to do that? So how are we trying to improve things and improve our support for health services in reviewing and learning from incidents at Safer Care Victoria? We're actually changing our model for training in incident analysis from just this whole focus on one method, root cause analysis, to broadening it to a stronger approach to the process of incident review. Making sure we do have a strong approach to collecting data, to interviewing people in an unbiased way, that we consider, we keep that information safe, that we keep staff and the family informed and involved along the way, okay? Because all of these stronger steps will result in a better outcome in terms of review and learning. Okay, we're going to look at not only, at the moment we require health services to use root cause analysis as the incident analysis methodology. We're going to broaden that to 3 different types, okay? Because there are some instances of adverse events in health that we know root cause analysis, just because it's very linear as a process, is unhelpful. Unwitnessed falls resulting in death, for example. Root cause analysis almost always comes up with nothing to learn. Okay, so it's not a really helpful tool. So we're looking at adding things like London Protocol and AXIMAP. London Protocol is a contributing factors framework method in health, and AXIMAP is a systems method used by predominantly non-health organisations, but it's very applicable to health. Cognitive interviewing and managing cognitive bias, we're going to offer training in these things. I thought as a clinician, I was good at interviewing people for the purpose of gathering information for a review for a serious adverse event. And it's not until I started this job and I got some training from my human factors specialist colleagues that I've realised that I've actually just been introducing heaps and heaps of bias into the way I do it. Okay, so we're trying to improve, help health services improve that, and also improve the way we manage our cognitive bias as investigators or as reviewers. Okay, we're going to be offering training in human factors and system safety, and we're going to be doing putting a lot of our offerings online, so that when we do face-to-face training, it is very practical. Okay, so the expectation is you do your stuff online before you come and do the practical component with us. We're in the process at the moment of a co-design project that's looking at the consumer role in incident reviews. Almost gobsmackingly, we actually don't necessarily routinely interview the consumer affected by a sentinel event or a serious adverse event or their family. We don't routinely even interview them as a source of information to understand how we can learn and improve better. Doing that isn't easy, but it's something that we're going to produce some guidelines and some training around. We also want to make sure that we have good training and support for the role of the consumer on incident review panels. Okay, and we want to make sure that we keep open disclosure strong and as a separate process, because it's not the same thing. We want to make sure that, and pretty much it's close to actually nearly 100% actually, almost 100% of health services now have an independent expert, and that's only in the last year. Okay, so health services really stepped up to that. We want to make that easier by offering the peer platform, which is now live on that Safer Care Victoria website. It's a place where you can go and have a look for people who are suitably qualified and experienced to be an independent expert on your panel, and you can look for the skill set that you need, whether it be somebody from an allied health background, a medical background, nursing background, whatever it might be. Notably, we don't have any surgeons on there yet. Okay, I'm hoping in the next week we'll have a surgeon on there, but if anybody's interested, you can go to the same website and look at the application process of how you can be put on that platform as a peer reviewer. And the other thing we tend to do, both within our team and with the Safer Care Victoria Academy, they're part of my broader team. They're a multidisciplinary group of experts from various backgrounds, including medicine, nursing, health executive, human factors specialists, and we have 2 consumer representatives. There's a total of 11 of them at the moment, and they've been given advanced training in incident analysis, human factors and systems thinking. Okay, they're a resource primarily for Safer Care Victoria and the reviews that we undertake, but they are also a potential source for mentorship and coaching and incident review for health services as well. So if you do need support, you can ring me or my team, and some advice and support won't be too far away. If you want closer mentorship and support in undertaking the review, there are people who can help you do that.